The next point that we often face is blood culture and samples, lab analysis. So, I mean, obviously, blood culture in certain labs, you have to again tie up with labs. The sample has to reach them appropriately. And remember that refrigeration of the culture sample delays the output. So, ideally, you should send the sample quickly to the lab, but it shouldn't be cooled after you have collected the blood. And obviously, the volume of sample is important as well. So, maybe you are in a resource limited setting and you are not able to take a culture sample and you blindly treat, that becomes very challenging. So antibiotic resistance, I mean, we often discuss that as well, that we have a vicious cycle. I mean, when we have a sick baby, obviously these are immunocompromised babies who can worsen very quickly. And we know from the Dennis study and other studies that ESBL or multi-drug resistant bacteria gram-negative as well is responsible for more than 50-60% of the sepsis. So you won't be blamed for starting a very sick baby on meropenem or covering with broad spectrum covering ESBL as well. But the problem is not stepping down appropriately and starting it without having the backup of a blood culture report. So you're not really in a position to step down. So lumbar puncture as well comes into the picture. If you don't do the lumbar puncture, continuing the same antibiotic for 21 days means the chance of dysbiosis in the baby increases, and also the risk of multi-drug resistant. The longer the antibiotic stays in the system, the higher the chance of more resistance even to these agents. We know that meropenem resistance is very common now, and we are going for colistin and fosfomycin and everything. So it's not a good situation. We have two groups of babies. We have the babies where they are definitely septic, they are symptomatic, they are tiny, and they could worsen anytime. So you would go for these babies with the broad spectrum cover. And if you have a high inflammatory marker, you can be justified in using meropenem in these babies. If there is a risk for staph infection, they had central line, they're in hospital, you would add vancomycin. But giving vancomycin routinely for such babies is not justified. You have the group of babies where you have baby born is having respiratory distress. You are debating whether it is infection or TTN or aspiration pneumonia or anything like that. In those groups, you can start your first line. Doesn't matter what you give because you are giving just for the sake of protecting yourself. If the baby clinically deteriorates, you would escalate quickly. But whether you give ampicillin, gentamicin, even if there is no sensitivity in the population, by giving ampicillin, gentamicin, you are minimizing the exposure to the other drugs. If you are using amikacin and nitrimycin, for example, the resistance to those will develop as well. The exposure, the more you use such medicines, the more the resistance is going to come up. So we could optimize by avoiding unnecessary use. Where you have clear-cut sepsis, you treat differently. Where you're starting for the sake of doubt that you want to cover infection, and obviously you have to train your team to monitor the babies carefully, and when there is escalation needed, you would escalate. The other important point is inflammatory markers. I mean, don't do PCT in the first 2-3 days because the values are erratic and you cannot really guide. If you use CRP and the CRP has started rising, remember that the CRP has a lag. So by 24 to 48 hours is when it reaches the level, and having the 24-hour sample and at 48 hours if the CRP is rising, that's a natural trend. It doesn't mean you need to change antibiotics from Piptaz to meropenem just because the CRP is rising. So if you have started ciproflox or piperacillin to start with the aminoglycoside, you can stay on that and wait for the clinical response of the baby. Don't go by the CRP rising by 48 hours is expected. Don't use that as a reason to increase your antibiotic cover. So clinically monitor the baby, give more weight to the clinical picture. Try to get a culture as far as you can. Don't treat without a blood culture. And lumbar puncture, if you're not able to get the consent or you're not able to do it for any reason, document clearly. Of course, you have to again balance how long you will give the treatment. I mean, keeping the baby in hospital with the central line, or because access for 21 days is quite difficult as well in most babies, so it becomes challenging. So infection control to prevent such problems happening, and treating in a timely fashion with the appropriate antibiotic, not overusing and stepping down at the earliest possible. So it should be reasonable. Remember that our body's immunity can take over once the infection comes under control. So if you are empirically treating, you could try stepping back and monitor the baby after 5 days or so. You could change from meropenem to piptaz if you didn't get a culture positive and the baby CRP is improving. If there is clinical worsening, you could always retry changing. But keeping the baby on carbapenems for a long time without a clear indication is difficult. Stage 1 NEC or minor symptoms, apnea in a premature baby. So these are also settings where you don't want to escalate unnecessarily. If a baby goes apneic, sepsis is a differential diagnosis, but teach the staff to recruit the lungs. First prevent that by watching the breathing, and if the pattern is becoming shallow or baby has retractions, you increase the support non-invisively. Before it happens, ensure the humidification is done properly, ensure that the suctioning is not overdone, because the nose block is often a factor in these babies as well. So if you do the basics well and you think about every step of the way, so this is a request to all the colleagues, and the reason we are doing this is to try and avoid antibiotic misuse as well. For the baby himself or herself, it's a dysbiosis, that's an important factor. For your unit, if you overuse these antibiotics, there is a high chance of multidrug resistance in the babies colonized in your unit. But for the community, it's obviously a big issue. And we are not the culprits here. We are the victims actually, because we are working in an intensive field with high risk patients. Most of the antibiotic resistance happened from the last 20, 30 years of abuse in the community. The general physicians and the general pediatricians are jumping to broad spectrum antibiotics at the least indication. And of course, the cattle industry also has to blame as well. The poultry and cattle, they are using antibiotics for the animals and the animal husbandry. That has made a huge change. So unfortunately, we are in a position where we have a big problem with multi-drug resistance. It's very difficult to correct the problem. From our end, we can only step back at each stage to think about whether it's absolutely essential to go for this escalation or not, and step down at the earliest possible. But we are dealing with high-risk patients, so it's understandable if you feel strongly you start with the higher one for that sickness. But experience matters, and lung disease, which is severe, doesn't always mean there is sepsis. And if you have RDS and the baby continues to be on ventilator for 5 days, doesn't mean you need to continue antibiotics for 5 days. So you look at the picture, whether it is infection or not, and if it is not infection, try to stop the antibiotics by 36 to 48 hours in the early onset group. These are the babies who are mostly in our unit. So we can easily optimize the care without risking. And if you closely monitor these babies, you can restart the antibiotic if needed, if it's worsening. So this is regarding the antibiotic.